Okay, so we're going to do pneumonia now, and other respiratory diseases, but we're going to really focus on pneumonia for this. So the other infections are really over here, and it's pretty self-explanatory. Sinusitis means that you have an infection in the sinus. Rhinitis, you have an infection in the nasal cavity. Pharyngitis, epiglottitis, laryngitis, bronchitis, bronchiolitis, and so it kind of makes sense. But when we get down over here, we could have, if you have an infection in the alveoli, we could call it alveolitis, or we could call it pneumonitis. But we kind of coalesced, I guess, over the years. They just turned it into one thing, and that's called pneumonia. So basically, an infection of the alveoli, we just claim to call simply pneumonia. So remember what happens with pneumonia. All right, normally what happens when we have air going through, this is your alveolus over here, and you're going to have the blood vessel over here. Oxygen will come in. All right, now there's just air over here, so it's going to come in, and then it's going to pass through that very thin membrane, the simple squamous epithelium, and then the oxygen can go into the bloodstream. So it just easily passes through that very thin layer and go right into the bloodstream. The carbon dioxide can go from the blood vessel, can go right through that membrane and go back out and breathe it out. But now, when you have pneumonia, what happens with pneumonia is that the alveoli, the wall of it, this simple squamous epithelium is going to be very thick, right? It gets inflamed. That makes sense, right? So it's going to get inflamed, and as it does, because there's an infection there, it's also going to produce a lot of fluid, right? The cardinal signs of inflammation. You have all those inflammatory cells that go in there, and a lot of swelling. So because of that, we're going to have a lot of water happening over here, right? And it could also be pus. So now we have this oxygen that's going to come here, but now it has to go through all of this thickness to finally get into the bloodstream over here. Then you got carbon dioxide that goes from here, and now you got to go through all of this thickness, all this fluid to get out. And that's why we have people dying with pneumonia, because of the gas exchange is so insufficient to get in here, okay? So pneumonia, some kind of inflammation that goes to the lung and even to the parts of the bronchi if it actually ascends from there. So we have to worry about how we're going to name these things. Okay. So this is what nomenclature is how we name things. So we can name it by what the etiology is, the cause of it, or we could also call it by where it's located. So we could call it by etiology. We could call it pneumococcal pneumonia. This is pneumonia that's caused by the streptococcal pneumoniae bacteria. So we just kind of sum it up, or we kind of abbreviate it by saying pneumococcal pneumonia. If we have pneumocystis carinii pneumonia, we see that PCP. We see that often with AIDS and with immunocompromised patients. We talked about it before. We could have viral pneumonia, aspiration pneumonia, and so forth. Then we could also call it, like I said, by location. We could have bronchopneumonia, and that's like this, and I'll show you what that is, but you have these patchy areas of infected lungs, but they usually happens in more than one lobe. Then you got lobar pneumonia, which is pneumonia that affects just one whole lobe. If you've got panlobar pneumonia, that's going to affect one whole lung. Okay? And then double pneumonia just means that both lungs are infected. All right? So this is a picture here showing you bronchopneumonia, where you're going to have patchy areas occurring in more than one lobe. Or lobar pneumonia, it's going to affect one whole lobe. One lung. Okay? So we call the pneumonia by the etiology, or we call it by where it's being located in the lung. We also have something called a superinfection. A superinfection is a situation where pneumonia is caused by one microorganism, okay? MO is microorganism. So it's caused by one microorganism, usually a virus, but then it lets the lungs be vulnerable to be affected with another microorganism. So we kind of just say that it's super infected. We have two causes of this pneumonia, okay? That's what happens with that. Then we have pneumonia syndromes, and this is when the microorganism is not identified yet. So we have them grouped into settings, and we have different settings over here. So this is where, you guys remember when you took microbiology, you did something like a culture and sensitivity. So you cultured the specimen, and then you had to do a sensitivity. So we culture it first, that's the C part of the CNS, and then we do the sensitivity. And sensitivity, you guys did when you did antibiotics. Remember taking a Petri dish, and you put this machine on there, you squeeze something down, and then it lies down like six or eight different circles on there, and that had like an antibiotic, and then you close the Petri dish, you intubate it for like at least 3 to 4 days, you take it out, and then you see these zones of where the bacteria won't grow because it's sensitive to certain antibiotics. So that's the whole thing. We have this thing called, you want to take some of the sputum from this person's lungs, and you want to test it. Now, a lot of times we don't know if they are, how to put this, we don't know what the microorganism is, but we got to start them on something because you can't wait 3 days and not give them any antibiotics. We got to give them something. So what it is that if the person got pneumonia and it's in one of these groups, so in other words, if the person got pneumonia and he was in the hospital, then there is the most likely causes of hospital-acquired pneumonia. They're going to give you a broad spectrum antibiotic to make sure it covers those things, because those are the more common things. We give them what we call empiric antibiotics. And usually, after about 3 days or so, we could actually see if the pneumonia is getting better. If it's getting better, we're going to keep them on those medications, all right, those antibiotics. If after 2 to 3 days he's not getting any better, then they're going to check, because when they did this, the culture and sensitivity of your sputum, the sputum CNS, it takes 3 days to incubate that. So now, 3 days later, if the person's not getting better, they're going to take a look at that CNS of the sputum. They'll see what the actual culprit is, all right, so they can identify the culture. But they also say that, hey, you know what? This is going to be the better antibiotic to use, because you can see what antibiotic is going to be most sensitive to that bacteria. So that's what a culture sensitivity is. And again, just to sum it all up, is that when someone comes in with pneumonia, we don't know what medications to give them for that particular bug or that particular microorganism. So we're going to give them the best spectrum that usually will cover one of these 5 different things. So it covers the most common bugs in those areas, or microorganisms. If they're getting better after 3 days, super, we'll just leave it the way it is. The antibiotics are working. If they're not getting better, then they're going to take a look at that culture and sensitivity, because now the results are out, and then we'll see if there's something, a different antibiotic we'll switch them to. So that's what that comes down to. Okay? Questions about that? No? Okay. All right. So treated most, 75% of pneumonia is treated, 75% of pneumonia that is treated is because of bacterial reasons. Most viral pneumonias, they usually don't need much antibiotics. They just usually, it's self-limiting. This is where you see those cases like walking pneumonia. They're just walking around and it's fine. So that's where, and it gets better like usually after 3 to 4 days or so. Okay. So, but most of the cases they're bacterial on there. So what? How can you get pneumonia? Well, there's only 3 ways you can get it. Either someone sneezes on you, and that's where air droplets, like coughing and stuff, that can go down on you. Touch your mouth, then it goes down into your lungs. You could have aspiration of gastric contents. What will happen in this case is that when someone aspirates, they're gonna, the vomit that comes from the stomach goes up to the mouth, and now you have a lot of this acid that's up there. And if it goes back down, but now it goes down the trachea and into the lungs, it's starting to burn holes into those into the lungs. Those areas that the acid is going to burn holes in, it's necrotic, it's gangrenous. So what happens here is that that's a great medium for bacteria to grow on. And what will happen is the bacteria will start growing on there and cause pneumonia. So, and then the other way you can get it is just via blood. So it comes from some other site. So you can have osteomyelitis, so you have a bone infection that goes into the bloodstream, the bacteria, and then it goes throughout your whole body and eventually will land and start seeding on your lungs and causing pneumonia. All right? So it's either through air droplets, through aspiration of gastric contents, or through the blood from some other source. Signs and symptoms of pneumonia. You may or may not have a fever. You'll have some shortness of breath, some coughing with a lot of production of sputum, and chest pain. Remember to start making a list of all the different things that can cause chest pain, because that is one of the #1 reasons why people go in to see doctors, let alone go in to see into the hospital. All right, that chest pain. Keep in mind, you got a gallbladder here. That gallbladder can actually cause certain diseases, and since it's so close to the lungs, it could actually radiate up to the chest, and that can cause chest pain. Okay? The chest x-ray, this is just a rule of thumb. Bacterial tends to affect only one lobe, but viral and fungal, they actually will cover the entire lung. That's the rule of thumb. It's not there all the time. So again, with something like this, if you see a black area, that's saying that air is in there. There's nothing that's disrupting the air. When you start seeing white areas, that's telling you there's either some soft tissue or bone there. So in an area over here, you can see in this area here that there must be some sort of consolidation. That there's some kind of effusion that's going in there. A lot of water, okay? So this is where the infection is. You can see it's up here in this area up here, okay? So congestion due to the pneumonia. So we have community-acquired pneumonia, all right? In this case, this is the most common acquired pneumonia that we have. Most common cause is going to be streptococcal pneumoniae. This is also known as the pneumococcal pneumonia. Risk factors: advanced age, diabetes, heart failure, COPD. So questions about should you get the pneumococcal vaccine? Well, it varies. I would say anybody who's elderly, all right, 55 years and older should get the pneumococcal vaccine. If you have diabetes or heart failure, COPD, these patients, and there's a few other diseases, these patients are recommended to get the pneumococcal vaccine. Okay? Signs and symptoms of this. They usually will have a sudden onset of fever and chills. Okay? They produce a yellow kind of cough. Right, so, and you've got yellow that's coming out. They usually will have chest pain. The white blood count is up, and they may either have bronchopneumonia, where it's going to be in more than one lobe of patchy, or it could be a whole lobe itself that looks like that's being affected by the pneumonia. Okay. The treatment is pretty much they can get antibiotics at home. However, if their respiratory system is compromised in one way or another, they're just not breathing properly, the oxygen, they're turning blue, then obviously they're going to be going, they need to be hospitalized. Okay? Nosocomial acquired pneumonia. What does nosocomial mean? Yes, hospital acquired. So this is where they come in for some other reason into the hospital, and they come in because of epilepsy. They're in there for, let's say, 10 days, and all of a sudden they catch, and now they have a new onset of pneumonia. So this is where they get it in the hospital. There's a lot of sick people in there, right? So the most common cause is that we're going to see Staph aureus, E. coli, Pseudomonas, all right? But do keep in mind that we have something called MRSA. That's methicillin-resistant Staph aureus. Now, this is making a lot of news for the past number of years. Methicillin is in the family of penicillins, but this is what we consider the big guns. I mean, if there's a lot of crime on this campus, you're not going to ask for the Army to come in. That's like the last resort, right? You don't want to get the big guns over here. So this is the same way here. I mean, if you treat pneumonia and you try different antibiotics, then the last resort, if they're not getting improved, then the last resort is like, we got to give them methicillin. These are the big guns. So this is why it's scary. Two reasons. One, if someone has Staph aureus causing the pneumonia, and they're resistant to methicillin, now we can't use the big guns. So we're kind of at a dead end. What are we going to do where we've used all the antibiotics we could, we can't use the big guns? So that's a big problem. The other big problem is that it used to be nosocomial, but now we're realizing more and more patients are getting it as a community acquired. It's out there in the parks. It's out there in the bowling alleys. It's out there in the schools. So MRSA is getting a lot more recognition now because it's not just nosocomial acquired in that sense, okay? We also have another one, which is, it's creeping up. It's not there so much, but it is creeping up, something called vancomycin-resistant enterococcus, VRE. So that's another one that's similar to this, except it's a different bug and a different medication. Okay? Questions about that? Okay. So risk factors. Risk factors. If you have some other severe disease, if you have prolonged antibiotics already for another reason, let's say you're on, you have osteomyelitis, and now you got to get antibiotics for 6 weeks. There's a good chance that you might get pneumonia because of this. Okay. Also, internal medical devices. So catheters, IV catheters. So not just urine catheters, you also have IV catheters. Anything that you're going to put into the person's body, all right, is going to introduce bacteria, because now you're actually telling the bacteria, just follow the catheter all the way in, and you can come right inside the body. It's fine. That's basically what's happening here. Mechanical ventilators is a big issue, because you're actually making that tube go right down to the lungs. You're making a wonderful trajectory for that bacteria to go right to the place you don't want them to go. So someone who's been on mechanical ventilators, respirators, for a number of weeks, maybe 1 or 2 weeks or so, they're at a big risk of developing nosocomial acquired pneumonia. Okay? So make sure you understand these reasonings over here. Okay? Or the risk factors. Aspiration pneumonia. Okay. For this one here, aspiration, like I said, you're aspirating some gastric contents. Right? So that acid's going to come up, and it's going to go back down into your lungs. So it's coming from the stomach and going up. But there's 2 things that are going to cause pneumonia for this. All right? One, just the corrosive effect of acid going down onto your lungs is going to burn holes into your lungs, and that's going to create a necrotic area that bacteria love to grow on. The other thing is, because it goes up to your mouth, the mouth is loaded with bacteria, and normal flora is there. So now all this normal flora is going to follow where the aspiration goes down into your lungs, and you're going to introduce a lot of bacteria in there. So you have 2 reasons. One, because of the corrosive effect from the acid from your stomach, and 2, because it's loaded with bacteria from your mouth, the oral cavity. Risk factors are people with debilitations, comatose or nearly comatose patients, post-stroke patients, and also think of just alcoholics, where they just fall down and they vomit, and then it goes down the wrong pipe and goes down into your lungs. You see that a lot too. Okay. They can also develop lung abscesses. All right. So it often occurs. The sputum that comes out, they call that, is usually a very foul-smelling kind of a smell to it. It may lead to sepsis, which then can go all over your body, of course, including your brain, and that can cause encephalitis or meningitis. Okay. It's a very poor prognosis. Like I told you before, when we dealt with acute respiratory distress syndrome, any kind of aspiration is going to destroy those lungs. If they're not going to die from ARDS, they're going to definitely die from this pretty severe pneumonia. Okay. We also have chronic pneumonia, and most common causes of this is usually someone with tuberculosis or any kind of the fungi that happens. All right. You usually see this more often in immunocompromised patients. So think of HIV, AIDS. Okay. Candidiasis. So the oral thrush that's in your mouth, if that goes down into your lungs, that can actually cause problems. Okay. We also have pneumonia in immunocompromised patients, and the one that that's usually the most common cause of death in immunocompromised patients, HIV, and that's where we're talking about the PCP, the pneumocystis coronae pneumonia, right? PCP.